Hello, everyone, and a very good afternoon. This is Neeraja. I'm a senior genetic counselor and currently the vice president of genetic counseling at Mapmygenome. And it's an absolute pleasure for me to have Dr. Bharath here with me. Dr. Bharath Reddy, he's a consultant pediatric pulmonologist and a sleep specialist, and the director of Shishuka Children's Specialty Hospital. He's also been taking a lot of courses, and he's an author of the director Doctor's Chronicles. He's here with us to talk about sleep-related issues, especially in children with genetic conditions. It's going to be an insightful talk. I request everyone, whoever has questions, to please put it in the Q&A section. I will take it at the very end of the conversation. Thank you so much, and welcome, Dr. Bharat. I'm looking forward to your insightful thoughts on this topic.
Thank you, Neeraja. Thank you for the introduction, and thank you, Prasanna, for this invitation. I think this is a topic that we need to increasingly talk about, primarily because this is something which is highly neglected. And I'm very glad that this topic was chosen and we're able to communicate this topic to a wider audience today. So, sleep disorders in children with genetic syndromes is something very close to my heart, primarily because we do see a lot of children with genetic syndromes coming with sleep issues which are not addressed. And our goal still remains on how we can optimize the sleep for all of these children in a much better manner. But why is this topic so important? We do know that almost 1 to 2% births are genetic disorders. It's not rare anymore. And we as pediatricians see a lot of children with genetic disorders. But there still remains a lack of awareness among many clinicians and doctors. And most sleep issues end up getting ignored and are only attributed to the syndrome. They say it's because of the hyperactivity, because of the developmental delay, or they attribute it to other reasons of the syndrome, and sleep issues tend to get ignored. But what is important for us is that sleep problems are treatable if they're identified early. And very importantly, it improves the quality of life for the child if treated early. And if not treated or under recognized, it can result in long term serious consequences as well. We need to understand that just because it is an entity like sleep, which is so natural, we tend to ignore the consequences of it as we tend to not have adequate amounts. Now, what about the pediatric sleep clinic that we run? We see a lot of patients. Of course, we see infant sleep issues, OSA, etc. But you have to realize that a large chunk of them do end up being children with neuromuscular conditions like Duchenne muscular dystrophy or spinomuscular atrophies and varied genetic conditions, right? From Down syndrome, Prader-Willi syndrome, MPS, Smith-Magenis syndrome, Cruzon syndrome, osteogenesis imperfecta. So almost 15 to 30% of sleep clinics are of children with genetic syndromes. So this was an article we published in the Karnataka Pediatric Journal, and this was way back in 2021 when we first started the clinic. And now it is, of course, way higher than this as well. Going on to the first most common syndrome that we encounter is Down syndrome, right? And Down syndrome is not relatively uncommon for us. And this is something that sleep issues in Down syndrome is something very, very common as well. Due to its high prevalence of almost 1 in 1,000 to 1 in 1,100, almost 21,000 children per year are born with Down syndrome in India. It may be trisomy 21 or a combination of mosaics. We do have varied clinical features as well. But what's important is the significant sleep issues associated with children with Downs compared to typically developing children. It is shown that it is much, much higher. Firstly, we go on to nighttime awakenings. Nighttime awakenings are almost 32% in Downs versus the 10%. Mouth breathing is 73% in children with Downs versus 33%. Loud snoring, almost 43%. Apneic episodes. When I say apneic episodes, it means breathing being stopped at multiple periods of time. Sleep talking, teeth grinding, bedwetting, sleepwalking. And you see, almost all conditions are almost 2 times to sometimes even 8 times higher in children with Down syndrome compared to the general population. So this tells us that children with Down syndrome are special indeed, but also have a high amount of sleep problems which need to be addressed. So the factors contributing to the sleep disorder breathing in Downs especially is because of the narrow and collapse of the upper airway. So this upper airway, which is this portion of the air pipes, they tend to collapse very easily. They have a smaller oral cavity because of the enlarged tongue. The tone of the muscles all over the body is generally lower, so hypotonia of the airway muscles also exists. There is also an enlarged tonsils and adenoids. They also are prone to develop obesity. They have other conditions such as asthma and GER, which add on gastroesophageal reflux, which add on to the problem of sleep disordered breathing. How significant is it? Nearly 50 to 100% of children with Downs end up having OSA eventually. A study done shows that nearly 60% have shown abnormal sleep study by the age of 3.5 to 4 years, and 90% between the age of 19 years have snoring. So the American Academy of Pediatrics now recommends that sleep study or polysomnography needs to be done for children with Down syndrome, for all children with Down syndrome, by the age of 4 years. What are the other treatment options that we do? We do nasal rinses. We ensure the nose is relatively clear. We use nasal decongestants. We sometimes use steroid sprays and antihistamines if they have associated allergies to keep the nose completely clear. Sleep positioning can work, like keeping them on a side or propped up. But eventually, after we do a sleep study, if it ends up being significant and positive, we go on and do an adenotonsillectomy and remove the tonsils and adenoids. Many children are started on positive airway pressure therapy, which is in the form of CPAP therapy, and very few children end up requiring a surgical reconstruction of the upper airway, uvula, soft palate, or tongue. But a large chunk of them do go on to positive airway pressure therapy. Now, if you look at this child, right, many pediatricians would see this child in an outpatient and not even address it. Say, oh, this child doesn't look syndromic to me. But the most important point which we as sleep specialists pick up in such a child is the jaw, which means that the jaw here is much backwards, a retrognathia or a micrognathia as we call it. Now, what is important is even subtle changes of the face, subtle changes of dysmorphism from any syndrome, be it Downs, being abnormalities of craniofacial abnormalities, all of them may have a jaw abnormality. And this jaw abnormality causes a significant problem in sleep disorders. Reason being the moment the jaw moves back, the tongue moves back. The tongue tends to fall backwards into the airway. And this happens more so during sleep. And that results in many children having sleep disordered breathing or obstructive sleep apnea. An important condition we talk about is Prader-Willi syndrome, which occurs due to deletion of paternal copies of 15q11 to 13. And the prevalence of Prader-Willi also is quite high, with 1 in 8,000 to 1 in 16,000. Most common features we see are hypotonia, obesity, hyperphagia, some degree of developmental delay, short stature, and dysmorphism. But what is the sleep problems that we need to encounter in Prader-Willi syndrome? The most common that I see is obstructive sleep apnea. The large chunk of them also develop what we call as central apneas. Some of them come with excessive daytime sleepiness, where they're sleeping continuously through the day, multiple arousals in the night, or waking up many, many times in the night, and a condition called narcolepsy, where they have an increased propensity to sleep during the night, and it is almost uncontrollable. But the most common we feel is obstructive sleep apnea. So why do children with Prader-Willi syndrome develop obstructive sleep apnea? The first most important problem they face is obesity. Here, the obesity is very difficult to control. The hyperphagia, the need to eat continuously, is also very difficult to control in children. So this results in a lot of them developing obstructive sleep apnea. We also see a large chunk of them developing hypotonia, where the tone is very, very less. We see adenotonsillar hypertrophy, where just like regular children, where the most common cause of sleep disorder breathing or OSA is adenoids and tonsils, in them as well, adenoids and tonsils contribute to a large chunk of the sleep disorder breathing. There can be a hypothalamic dysfunction, or what we call as central apneas. Central apnea is where your main center for breathing comes in. So during sleep, if the main center, which is expecting you to breathe, is not sending the signal at that time, so you end up having a lot of what we call as central apneas. Central apneas means the lack of the signal coming from the brain makes somebody not breathe for a certain period of time in the night, right? And this is very common again in children with Prader-Willi, what we call as hypothalamic dysfunction. We have scoliosis because of the spine abnormalities, respiratory muscle weakness, and dysmorphism. And all of these add on to a child developing obstructive sleep apnea in a child with Prader-Willi syndrome as well. We also know a lot of children with Prader-Willi receive growth hormone therapy, right? So growth hormone therapy is one of the forms of therapy which improves the indexes like your respiratory distress index, your apnea hypopnea index. These are the different parameters we use to assess how significant the OSA is. So studies have shown that giving growth hormone had improved a lot of the obstructive apneas and central apneas. But what happens is when a lot of children receive these therapies, right from growth hormone therapies, other conditions which receive enzyme replacement therapies, in all these conditions, the OSA can worsen in the first few months because the lymphoid tissue, that's the adenoids and tonsils, tend to enlarge. So all of these children should mandatorily undergo a pre-growth hormone polysomnography, and you need to do a sleep study, treat the obstructive sleep apnea, and only then we go ahead and decide whether we can start CPAP therapy, and then only growth hormone can be given. So the current Prader-Willi Syndrome Foundation recommends that yes, we have to do a sleep study mandatorily before we go ahead and do a growth hormone therapy. And if the sleep study shows obstructive sleep apnea, we treat the OSA either in the form of CPAP therapy or adenotonsillectomies, and only then we can start the growth hormone therapy in these children. So sleep study is mandatory, especially in children with Prader-Willi syndrome, prior to initiating any form of growth hormone therapy. This was this paper that we published on children with Prader-Willi syndrome and their sleep findings in children with Prader-Willi syndrome. And what we found was that the clinical syndromes, the clinical symptoms, now many of the patients that I asked about, do you have any sleep problems? Is your child sleeping well? Is the child waking up many times? Is there snoring? Is there daytime sleepiness? Is there other symptoms suggestive of sleep disordered breathing? Most parents said no, there was no problem at all. What we found in the sleep study was completely contrary to the information which was given by parents, which also told us that in children with genetic syndromes, the perception of sleep and the history of sleep that we elicit as doctors may not match what ends up being there on the sleep study. So, what parents see is not going to match what is there on the sleep study, right? And this is standard for all sleep disorders in genetic syndrome children. That the sleep disordered breathing or the OSA is much more severe on a sleep study than what we see physically, right? Saturations were much more lower. That means the oxygen levels were much, much lesser, right? The number of times a child stopped breathing, what we call as apneas and hypopneas, were much higher, which brought us to tell that there was no correlation between clinical history and what we found on sleep studies in children with Prader-Willi syndrome. This brings us to the point that yes, it is mandatory for us to do sleep studies in children with Prader-Willi syndrome, irrespective of their symptoms. Another common condition I encounter is mucopolysaccharidosis. Now, MPS, as we know, is a common condition where you see skeletal dysmorphism, and the dysmorphism occurs predominantly in the facial structure, right from your jaw to the maxilla to the nose. And because the airway is so obstructed by the large tongue and the nose and the jaw, we tend to see obstructive sleep apnea very commonly in children with MPS. The prevalence is almost 1 in 16,000 to 30,000 births. It occurs, of course, due to a lysosomal defect where there's an accumulation of glycosaminoglycans and mucopolysaccharide. There are different types of MPS, type 1 to type 7. Most of them have associated developmental delay, but skeletal abnormalities. But what I'm concerned is about the skeletal abnormality, which occurs predominantly in the facial structure. Because the skeletal abnormality in the facial structure occurs, they are very, very prone to develop obstructive sleep apnea. As you can see here, that in children with mucopolysaccharidosis, airway narrowing was very, very high. Enlargement of adenoids and tonsils were also high. We saw a large tongue, nasal obstruction, narrowing even at this level of the larynx can undergo narrowing. Others have other problems such as lung issues, which also we deal with as a pulmonologist. But I'm going to talk only about what we see in the sleep study in these children. So what we end up seeing, why is it so obstructed in children with mucopolysaccharidosis, is one, as you can see, the tongue in the first image is so large. And when the tongue is so large, the amount of air that is able to pass through during sleep is significantly reduced. We also see the air pipes. This is your air pipe, or what we call as the epiglottis and the larynx. They tend to collapse. They tend to be obstructed by the accumulation of these mucopolysaccharides at multiple points in the airway. Now, the reason why we as pulmonologists are the ones who primarily practice sleep medicine is because the airway and sleep disorders are very, very interconnected, which is why pulmonology and sleep tends to go together, and we tend to do airway management to resolve the sleep issues. So they have most commonly airway obstruction, and because of the airway obstruction, they also can have other restrictive lung diseases where the lung is not able to expand. And because of all this, they have OSA. OSA over a period of time develops what we call as hypoventilation. Hypoventilation means that they are accumulating carbon dioxide inside the body, and over a period of time, even during the daytime, they start developing hypoventilation and eventually cardiorespiratory failure. Now, why is this important for us? It's important because we need to treat very, very early, right? The earlier we treat, we know these children are going to go on this trajectory. When we already know this trajectory, why are we waiting for them to develop hypoventilation or respiratory failure? If you start administering CPAP therapy very early, a lot of it can be avoided. Here we are showing that CO2 accumulation, that's carbon dioxide accumulation, is one of the most important problems that we see in these children with obstructive sleep apnea. All of children with genetic syndromes, when they have OSA, they start retaining carbon dioxide. And because they keep retaining carbon dioxide over a period of time, this starts affecting their overall quality of life. So it's important that initially we see only oxygen levels dropping. Eventually, we see obstructive sleep apnea. We see hypoventilation later and carbon dioxide accumulating. 80% of children with MPS have sleep disordered breathing. And we sometimes do what we call as spirometries, spirometry or lung function testing, to initially start picking up when are these children going to develop this hypoventilation. But that being said, the gold standard test is a sleep study to identify these children. So many of the children who meet me are those who are referred for a sleep study prior to doing orthopedic spinal surgeries, and we initiate NIV or CPAP therapy. And with that, we ensure that the children is breathing really well during the night. Oxygen levels, carbon dioxide levels are maintained. And with that, you can easily go in for surgery. Some of the children also undergo hematopoietic stem cell transplantation or bone marrow transplantations. Again, a lot of bone marrow transplantation specialists, they refer to us before doing BMT. BMT is a very, very expensive endeavor for a lot of parents. And we need to ensure that the oxygen is being maintained in the body before we go ahead with a BMT. And the only way we can do that is by doing a sleep study. And after we do a sleep study, we start on CPAP therapy if it's required and ensure that the child's oxygen and carbon dioxide levels are maintained before they go ahead with a extremely expensive endeavor like bone marrow transplantation. The other common cases that meet me are those with cleft lip and palate. We have shown that in a lot of studies that children with cleft lip and palate do also have a large amount of obstructive sleep apnea. It's even the cleft that causes a large amount of sleep apnea as well. 68% had OSA, with again only 12% reported with normal studies, but most of them had increasing amount of OSA in their sleep study. As I told you, the correlation between clinical history and the sleep study is usually not there in children with genetic issues. Here, if they have any opening, we see that the nasal floor closure is associated with the nasal vestibule. They can have septal deviation and thickening of the palate in certain areas, and these predispose to obstruction. Many of them post-surgery still end up requiring additional procedures like a tonsillectomy. Many of them do end up requiring even CPAP therapy. But what's mandatory is to do a sleep study before and so here, the focus lies predominantly in the dysmorphism. You see that the jaw abnormality is very significant in these children with Pierre-Robin sequence. Here they have multiple issues. They have a cleft palate, which is adding to the problem, a micrognathia, retrognathia, adding to the problem, glossoptosis, where the tongue is grossly enlarged and contributes to the problem as well. So the main problem here lies with a small jaw. The tongue falls backwards and it improves on positioning on the stomach. Sometimes in these children, we also use nasal tubes and nasopharyngeal airways, where we use a tube to overcome that obstruction and the child is able to breathe temporarily. And even before you discharge a child from surgery, we always need to do a sleep study and make sure the oxygen levels are maintained. Similar with conditions like Treacher-Collins syndrome, where they're going to do cleft lip, cleft palate surgeries, as well as the jaw surgeries. Always do a sleep study, start on CPAP therapy before we do anything. Another condition we have is called as ROHAD syndrome. Here, ROHAD refers to R stands for rapid onset obesity, RNO. H stands for hypothalamic abnormalities, H for hypoventilation, and AD for autonomic disturbances. Obesity. Obesity is one of the most common associations with obstructive sleep apnea. So we need to understand that any child which develops obesity little rapidly or faster, they develop severe obstructive sleep apnea and also are very, very uh, prone to develop hypoventilation or accumulation of carbon dioxide. So the children with Frohat syndrome who were referred to me were all those who actually were picked up after a surgery. They underwent surgeries for some other reason, right? For adenoids and tonsils, or probably some other surgeries like hernia surgeries, etc. What happened was that after the anesthesia, they were just not able to wake up, right? And this was because of hypoventilation and carbon dioxide accumulation, which had happened. And this was not picked up pre surgery because a sleep study was not done pre surgery. And these children had to go onto the ventilator for a longer period of time after the surgery and had to be weaned off the ventilator later. So, if we don't address sleep issues in children with obesity, they are prone to end up having severe obstructive sleep apnea and hypoventilation with time. This was my publication about Smith-Magenis syndrome. So this was a child who presented to me predominantly with inverted sleep rhythm. So although I've been talking about obstructive sleep related to airway breathing, other common sleep issue we find is what we call as like circadian abnormalities and inverted sleep. So this baby was sleeping only during the daytime and completely awake during the night. It was very difficult for the parents to like live like that. It's been going on for years, right? Sleeping during the day, wake up during the night. This was the standard process, right? Uh, a lot of doctors had just started melatonin. They just give drugs and say, give melatonin and try to make the baby go to sleep. That is not the strategy. So, as a sleep specialist, I can confidently tell you I rarely use melatonin or drugs for a child to go to sleep. We need to use other methods, and drugs are not the solution for any sleep disorders at all. So we had to do behavioral therapy. We had to do a part of sleep coaching where we started the child to change sleep patterns and advance the time. And with time, we were able to establish a good sleep hygiene and a good sleep schedule for this child. Achondroplasia is where we see the child having a compression of the sleep center and the breathing center right at the skull, what we call as the foramen magnum, where the spinal cord leaves the skull, right? That point gets compressed in these children with achondroplasia. And because that point gets compressed, their signal from the brain for breathing stops during sleep. So they develop something called as central apneas. So, but remember, all these happen only during sleep. So during sleep, their central point, which is supposed to generate the breathing, that stops multiple times, and they develop central apnea, and eventually hypoventilation and carbon dioxide accumulation, and therefore they are prone to develop rising carbon dioxide levels and dropping oxygen levels over a period of time. And we do go ahead and start them also on CPAP therapy, and they respond beautifully. But it's very important to start them early, right? Today, I think a lot of endocrinologists and geneticists are very well versed with sleep issues and they refer very early. So, even children with Prader-Willi and achondroplasia, I get them within the first year itself, where they're diagnosed very early as well. Nobody's diagnosing them late now. They're diagnosed early. With increasing genetic testing, it becomes much easier to confirm the diagnosis. And once we know the diagnosis, we know the trajectory. We know this is how a child with Prader-Willi, this is how a child with Downs, this is how a child with achondroplasia, MPS, all of them are going to behave eventually. Their airway is not going to be maintained. Their oxygen and carbon dioxide is not going to be maintained. And remember, as doctors, that has been our primary goal. We have to ensure breathing. We have to ensure oxygen being maintained. That is the main goal of managing sleep. So I hope that I just gave a brief overview of all the sleep issues in children with genetic syndromes. The take homes that I would like to say is that one, yes, sleep issues in children with genetic syndromes are varied and it is very, very common. We should screen all children with genetic syndromes for sleep issues, primarily because the dysmorphism adds to the problem, as well as the associated fact that the syndrome itself is associated with genetic problems. Thirdly, the clinical picture or the history that we get from parents and what we see on sleep studies never correlates, shown by multiple studies. There's what we call as a clinical dissociation from the testing. So, which means that sleep study is the only way that we can confirm whether the child has obstructive sleep apnea or not. Treating them early after doing the sleep test is very, very important because it improves the quality of life, helps them in their development, as well as helps us prevent hypoventilation and respiratory failure. The primary treatment in most children with genetic syndrome remains CPAP therapy. Though we spoke about surgical methods, they are always secondary. CPAP therapy, all we have extremely good compliance and adherence. A lot of our children use it, and we don't face a problem. It's just the way that it is initiated or the way that we start CPAP therapy needs to be done only by trained personnel. And we ensure that they maintain CPAP therapy really well. And a lot of children end up doing well during the day because of this. So thank you. I'll open up the session for questions because I thought question and answers might be much more useful because there are so many conditions I could talk about. But let's open it up for question and answer. Over to you, Neeraja.
Thank you, Dr. Bharath. And it was very well described and with really good examples, especially with a varied, set of genetic conditions. One question that we have here in the chat box is what about cystic fibrosis? Are there kids who have sleep problems, especially with cystic fibrosis?
Yeah, so cystic fibrosis is associated with sleep issues as well, and we as pulmonologists see that very common. Firstly, we do see a larger amount of problems with awakenings. They tend to wake up much more because of their lung issues and dropping oxygen levels. So they are more prone to develop a drop in their oxygen levels. One is because, see, in all of us, when we sleep, our oxygen levels drop naturally, right? It drops by some extent. This becomes more exaggerated in children with underlying lung problems like cystic fibrosis, right? So that is important. So we also do sleep studies in children who have other lung issues, right? From interstitial lung diseases, we see alveolar proteinosis, children bronchopulmonary dysplasias. All of them also not we all undergo drop in oxygen level, but somebody who has a lung issue, it tends to be much more significant. So we do a sleep study to see how significant it is. We have certain cutoff values. If it falls within the cutoff value, we still say there's nothing much to do. But it goes beyond the cutoff values, that's when we need to treat them. They do have other sleep issues as well, which I didn't speak about, which is things like insomnia as well as circadian abnormalities. So we also manage other kind of sleep conditions called circadian disorders, where your entire body clock cycles are distorted, right? They tend to end up feeling sleepy only very late, like 11 a.m., I mean, 1 a.m., 2 a.m., and therefore they end up having a problem going to school. So we also address those kind of sleep issues, which need to be addressed in CF patients.
Great. Thank you for answering that. And I would request all the attendees, if there are questions, please drop it in the Q&A box. So Dr. Bharat, I would like to ask you a question. There was one of my own cases that I had seen last year, and this is a girl who's had very delayed, in fact, I've written a case study on her, but she had very delayed diagnosis. She's 19 when we finally got her diagnosis. Initially, I think she had been suspected to have Rett syndrome, so MECP2. So back in 2008 is when they've actually undergone some genetic testing, even did MECP2 testing. Along with that, also did the chromosome microarray. Everything came back normal. Now they presented at 19 because of sleep issues. This is what triggered the whole diagnosis again and starting off, the genetic testing process. So they've actually taken up help from alternative therapy, and that is how they've come to genetics again. So coming to the genetics, we actually diagnosed her to have a GABBR2 gene mutation, which is it mimics MECP2. It essentially looks like that as well. They do have that very, ringling hand movements that we see with MECP2. So this child has had chronic sleep issues to an extent where the mom said she is at risk of developing sleep apnea because she's not been sleeping at all for the last 19 years. This child has gone for 3 days with no sleep. That's like what she does sometimes. So she also has a history of seizures. And till date, her sleep is not something that is manageable. She can sleep maximum for maybe an hour or two most of the days in the night, and that's about it. She's active through the day. So earlier when you started, you'd mentioned about how it affects, chronically affects the child's life. What I've also experienced is not just, and I'm sure you've seen this in your practice, not just the child's life, but also, the caregivers, the parents especially, right? So how and what is the value of bringing, so I would love to, have someone like her. What is the value of having a sleep study done now, and how can we help her right now at this point? 18 years have passed, so how do you think that would work for her at this point if therapies were delayed or not available initially?
Sure. So one is, of course, parents are the ones who are the most affected. We also have a lot of studies which show that, which talks about how parents' sleep has been affected, and a lot of parents' sleep is more affected than the child's sleep because they're just waking up, watching this child not breathing, not sleeping, right? So it's important that it improves the quality of life for the entire family, and we treat sleep as a family problem more than just the child's problem. So that's a very valid point. Now, when I talk about sleep study, we first need to take a sleep history. So, irrespective of talking about investigations, I've done a lot of training programs for doctors on pediatric sleep as well. We do it as almost 6 month diplomas, right? But a large amount of time I spend in telling doctors that history is most important, right? So, the first thing that how we would evaluate this child is we give them a sleep diary. We ask them to chart and clock out the sleep over a period of probably a week to 2 weeks, right? We need to really see how the sleep pattern is. That's where we end up diagnosing what is the primary sleep problem. So the classification of sleep disorders also says that the sleep disorders also classified like a medical condition itself. Like how you have classification of different disorders, we also have ICD which classifies sleep disorders. So you have to also decide which sleep disorder is this child falling into. Why is this child not able to sleep? Is this a circadian abnormality where the circadian rhythm itself is getting distorted? Is there an obstructive sleep because the moment she sleeps is getting obstructed, so the child refuses to go to sleep, right? Or is it just an insomnia? Or is it really a behavioral problem itself or a medical condition causing the sleep disorder? So we classify them into multiple categories. And based on these multiple categories, we are able to decide what further treatment that we need to do. So, how would I approach this child? First, I would probably take a detailed history. We give them a good sleep diary, and the sleep diary gives us the patterns. Is the pattern consistent? We end up seeing a certain pattern, and that pattern itself tells us which direction we're going into. And doing a sleep study definitely helps. The reason being, we need to understand what's happening in the brain. Why is this brain not sleeping, right? Or let us say the brain goes to sleep and the sleep brain is waking up. What exactly happened just before this brain woke up, right? And that gives us a huge clue to tell us what exactly is happening in this child. And then, of course, we start off on treatment, whether it being a medical treatment or whether it's going to be in the form of CPAP therapy, depending on the sleep condition. But with your patient, I would still consider circadian abnormality to be more significant than an obstructive sleep apnea. And circadian abnormalities, one requires medication in the form of different melatonin doses. We have it at different timings. It's about what time you're going to give it, what dose you're going to give. And also, we work on behavioral strategies. Like I said many times, it's not only about medication, it's also about using behavioral strategies and sleep hygiene strategies. So we have to do a lot of sleep hygiene coaching. Though it sounds like why are we doing therapy for sleep, right? But it is important. It's just like how we do therapy for many other disorders, we need to do therapy for sleep as well. And that's a specific form of therapy we do, which is called sleep hygiene management. So that's how we would approach the child too.
Great. Thank you so much. That's really helpful. So we have more questions. Someone's asked about when are sleep studies indicated, and can you explain the procedure, and does it require a sedation?
Sure. Let me just put up a slide. I think that's one of the things I wanted to put up the sleep study because I think I didn't explain that. Just give me a minute. Uh, I want to show the picture. Just give me a minute, sorry, because that will be easier for children to, for everyone to understand if I just put up the picture of the sleep study. Are you able to see my slide? No?
Not yet. Yes, now we can.
Yeah. So what we do in a sleep study, what we call as pediatric polysomnography, is that we connect different types of leads, right? So we connect leads which are to the brain, which is like an EEG, and we connect few leads around the eyes, right? So these leads which are connected are across the eyes and near the head or the scalp. These pick up the different stages of sleep. So we assess what are the different stages. So sleep is categorized into non-REM sleep and REM sleep. We need to identify non-REM sleep as 1, 2, 3. And we start identifying, is the first of all the baby going to sleep or not? See, many times you may be closing your eyes, you may not be in sleep. And many times you may think that somebody is actually awake and they may be in sleep stages as well. So we need to identify the different stages of sleep. And REM sleep, which we keep talking about, is very, very important because almost most sleep disorders are identified in this REM stage of sleep. And they mostly occur between 2 a.m. to 6 a.m. in the morning, right? And that is the time when maximum sleep disorders occur. So the first few leads that we connect are all identifying the EG, which identifies the brain stages, and the EOG, which identifies the eye movement. The next thing you see, we have put something here on the chin that identifies the jaw movements. And sometimes when people are biting their teeth, that gets picked up, especially with this particular lead here. We put a cannula in the nose, right? And you can see what's going in the nose is a simple cannula which picks up the amount of air which goes in and out, right? So this tells us when the breathing stops, it gets picked up very sensitively. So remember these sleep study machines which are designed, most of them are international ones. They are very, very, very sensitive to pick up the stopping of breaths even for a few milliseconds, right? And that picks up even the amount of air, how much is it reduced? Even by 80%, 90%, it's come down to 70% of its normal. That's what it picks up. And we have something which is connected to the chest and the abdomen, which are the abdominal and chest belts. These tend to pick up the movement of the chest and the abdomen and how you're able to breathe. And finally, we have a probe which is connected to the finger probe, which records the oxygen levels of the child. It looks like so many leads are connected, but this is mainly by trained technicians and trained pulmonologists. When we do it, it's not that difficult in a child because we sensitize them. It needs to take some amount of time of coaxing, but even children with all the severe genetic syndromes, they are end up getting coaxed to do the sleep studies, right?
Thank
So
you.
very important for us to do these studies. And as I said, it's not very difficult for us to do. Now, what happens after I do the study? So next day morning, the child has to just sleep with the parent. And next day morning, when we have a certain screen which shows us what all has happened, and in that we see how many times the breathing has stopped in the night. That is called an apnea. Then it also tells us how much of the airflow has decreased in the night. That is called a hypopnea. We have to watch every second of the sleep. And that we calculate how many times this happened through the night. And we have a particular value. And there's certain cutoffs beyond which we say beyond this value of breathing stopping or oxygen levels dropping, we need to treat. Below a certain level, we can still let it go. And we tell them come back again after a year. This also is useful for other conditions like circadian abnormalities, etc., to tell us, how much time is it taking for the brain to go to sleep. And like Neeraja mentioned, the patient, once they wake up, after they go to sleep, just before they wake up, it tells us what happens in the brain, what triggered this entire person to wake up, right? And that's the utility of a pediatric polysomnography.
Thank you. One more question is about potential long-term side effects of taking melatonin and what should we watch out for?
Yeah, so first of all, melatonin should not be taken at all, right? So that is something which we have to be very categorical that this is something which I think has been grossly misused and abused, not only in India, across the world. I see even pharma companies coming and, actually being angry with me saying you're a sleep specialist and you don't use melatonin. I don't even use melatonin, even as a sleep specialist. There are very specific conditions where it is indicated to be used. Like the only condition is circadian rhythm abnormalities. So only if you have a circadian rhythm abnormality, melatonin is useful because the circadian abnormality is because the melatonin is being secreted at the wrong time. So here you're giving the melatonin at the right time to reset it. That is the only reason. To make a child go to sleep, you should not be using melatonin. So if you ask me what is the maximum dose, what to do, you should never be using it at all.
Thank you. There's a parent who's written a question that her son has SMA type 2 and used to snore while he was sleeping, and he was 31 months when they had identified by a sleep study that the child had sleep apnea, for which they've been doing treatment. Their question is, other than sleep apnea, is there any other test that's, other than the sleep study, any other test that's preferable? And since he's 53 months now, 2.5 years old.
Yeah. So a lot of first is the sleep study gives us adequate information, but most importantly, we need to I'm presuming the child would have been started on CPAP therapy or BiPAP therapy after the sleep study. If it is not started and it will not reach that level where it required CPAP therapy, maybe your doctor will ask you to repeat it every year. But yearly, we repeat the sleep study. Now, at a point when the sleep study becomes abnormal, we decide on doing your CPAP or BiPAP therapy. And we then repeat the sleep study on your CPAP or BiPAP itself, which is called as a titration study. Now, what is the titration study? Is it tells us whether the pressures that we're giving is adequate or not, whether it's causing any effect on the body or not, right? And whether all the problems we saw in the sleep study are resolved. So we can decide only the pressures of a CPAP or a BiPAP based on only a titration study. So a titration study is mandatory for us to do in all children with neuromuscular disorders, because just setting a pressure is not enough for us. We have to set the right pressure. And that is monitored by a titration study yearly. Once they go into CPAP BiPAP therapy, we do the titration study yearly. Now, at some children, what happens for me is that we are giving the pressures and the pressures keep going up, right? And we are reaching a point where, listen, we're giving really high pressures in this child. And at that point in time, we do another study, another test, what we call as a sleep endoscopy. So what we do in a sleep endoscopy is we have to find out where exactly is the obstruction actually happening. Is it at the level of the nose? Is it at the level of the adenoids and tonsils? Or is it that soft tissue which is collapsing? So I do what we call it as DICE or DISC or drug induced sleep endoscopies. So what is drug induced sleep endoscopies? After we do a sleep study, we start on CPAP therapy, or let's say even in a children before we start sometimes CPAP therapy, parents are not sure that there is actually an obstruction. We give certain medicine to make the child sleep, induce natural sleep, and during that sleep, we take a camera and we observe where the obstruction has actually happened. And that gives us a lot of information to take a decision on whether this requires surgical correction, whether we need an adenotonsillectomy, whether we need to do CPAP therapy. So in a child with neuromuscular disorders like what you described, one is we start CPAP therapy, we keep repeating the titration study. If we find that the pressures are going higher than normal, we need to do a sleep endoscopy to find out where exactly this obstruction is happening.
Okay, one more question is, at what time can we expect a sleep disorder in a child with cystic fibrosis, and what are the signs of sleep disorder?
Yeah, so sleep disorders in cystic fibrosis, like I mentioned, has to be done by history itself. One, we take a detailed sleep history about insomnia, about sleep efficiency. But like I told you with other conditions, a spirometry gives us very good information, right? So doing an FEV1 and FVC, the moment the FVC starts dropping, that is when we're really worried about sleep disorders. So a spirometry, which I think all children with cystic fibrosis undergo spirometry regularly, but identifying at what time the value in the spirometry is dropping gives us a clear picture. So one of the benchmarks is 60%. The moment the FVC drops below 60%, they have to undergo sleep study.
Is it natural for most of the kids who have pneumonias or recurrent lung infections, even with kids? Do you expect those kids to also be at risk of sleep diseases?
No, they don't have any issues with sleep disorders because most of them are acute problems and the body tends to reset itself completely. So we don't, if someone has an acute pneumonia and is treated and goes home, we are not worried about us oxygen levels dropping there. For us, it's more of chronic conditions where sleep issues tend to manifest.
One more question that we see is, for a DMD child, should we do a sleep study?
Yes, for DMD children, it's absolutely mandatory because the most important problem that we face is hypoventilation. Over a period of time, when the muscles start becoming less efficient, the person stops breathing to the efficiency that is really required for the oxygen to reach the body. And we know this happens more during sleep first, and then it can start happening during the day. Eventually, that is going to happen. It is going to affect the muscles during the day, and you have to start putting on BiPAP therapy during the day eventually. But have we reached that point or no? Nowadays, we're so advanced that we can pick up all these way much earlier. And a lot of the DMD children have very good sleep, very good quality of life, primarily because all of this is picked up very, very early, right? So even before they develop a sleep issue, we do sleep studies because we know that it may not be picked up on their history. So we end up doing a sleep study or we end up screening on spirometry. So again, you will see a lot of neurologists, they ask for doing a spirometry, even in children with DMD, we look at mainly the FVC. When the FVC starts dropping on a spirometry, it's an indication that you have to do a sleep study and they're not generating the required efficiency of the respiratory muscles. And in the sleep study, we see whether it is reaching the point of hypoventilation, and we start on BiPAP therapy early in that.
You've answered that question. Thank you. All right, I don't see any further questions with this. These were very insightful discussion, Dr. Bharath, and thank you so much for your time today. And I think all the attendees also have asked really good questions with respect to what the next steps are. So takeaways really is to be careful about. I think even as genetic counselors and anybody who's seeing kids with rare diseases to really understand if we are seeing any sleep related issues and make an early referral so that it can definitely help and benefit the child overall long term. I also see that a lot of kids, especially with autism, the more the sleep, I mean, the poorer the sleep, it directly affects, their behavior also going forward. So that's again another major health concern that comes up with most of the families. So this was very insightful, Dr. Bala. Thank you for your time today, and thank you for all the attendees for asking very insightful questions as well. And Dr. Prasanna and to
Thank you,
ORDI, thank
Neeraja.
you so much
And,
for giving us the platform to have this wonderful discussion.
thank you, Neeraja. Thank you, ORDI, for inviting me for this session. But the take home, what I would like to end with is saying that almost all children with genetic syndromes do have sleep issues. And like I said again, we may not get the information that is required, and it's important that we do sleep studies much earlier and don't need to worry. I think one more question we didn't answer was someone asked, do we need to sedate the child for a sleep study? And I think the biggest worry parents have is with respect to sleep studies. We don't need to do sedation. We need to keep it as natural as possible. We try to keep the environment as natural. We ask them to even get their own blanket, get their own pillow which the child loves, get the toy which the child loves, and try to get the parent to keep it as natural as possible. So let's not be averse to sleep studies, and hopefully we manage sleep issues better in children with genetic syndromes. Thank you.
Thank you so much. Thank you for all the insightful conversations. Dr. Prasanna.
Thank you, Dr. Bharath. Thank you, Neeraja, for
You're
moderating.
welcome. Yes. Thank you, Dr. Bharath. This was very insightful.
Thank you. Have a great day. Bye-bye.
Bye-bye.